Now I'm going to ask my colleague, Dr. Kenzie Thrum, to introduce me, and then we'll talk about egg freezing.
Thanks, Caitlin. Caitlin needs really no introduction. She's a co-director at PCRM here in Burnaby, and she's also a clinical associate professor at UBC. Her practice surrounds infertility, of course, and transgender fertility care, as well as a lot on egg freezing. She's well known to all of us. She's very well known in the Canadian media, newspapers and magazines. There really isn't a week that goes by that you won't find her advocating for women's health in this country and globally. She's also the editor-in-chief of the BC Medical Association Journal. She serves as the Health Committee Chair in the TELUS Vancouver Community Board. I've known Caitlin for almost 15 years, and I'm super proud to be her practice partner as always. She was instrumental in starting this symposium 8 years ago, and she continues to be a very energetic steward of this really important educational event. So I turn it over to you, Caitlin.
All right, thank you very much. So today it's my privilege to talk about egg freezing. I structured my talk as why, when, and how, and really my goal here is that by the end of the talk, you feel like you have the most updated information because there's so much about this in the media. We want you to be able to talk to your patients in an informed and evidence-based, balanced manner about this topic. So I am a co-director of PCRM. I have to declare that we do offer egg freezing services. And how I plan to mitigate that conflict of interest, of course, is presenting you with data. And then a lot of the studies, they do use gendered language. And certainly egg freezing, particularly in our trans population, is really important. And it's important to acknowledge that we don't want to exclude that population of people. So let's start with the why. We see a lot about this in the media. Certainly fertility rates, birth rates around the world are declining. On this particular graph, Canada is right in the middle. You'll see of the developed countries, we're the red line there. In 2023, just a couple of weeks ago, they released the birth data. 1.26 children per woman is a historical low for Canada. So, in our population of nearly 42 million people here, in British Columbia, we have the oldest average age of mothers at 32.6 years. And for our Alberta audience, it's 31.2 years. It used to be 26 years old in 1976. So think about that generational change over the past couple of generations. In BC, the average is well below the Canadian average at 1 child per woman. So certainly fertility rates are declining. This is largely attributed to having children later in life. This is British Columbia data, fresh off the press, really just published up until 2023. And what you'll see here is this pink line is looking at 35 to 39-year-old age group, and those numbers are increasing. The very steep decline is in the 25 to 29-year-old age group. So what happens when we have children later in life is that family sizes tend to be smaller. And that's because it's harder to get pregnant. So women complete their families, or people complete their families with smaller numbers of children. As we get older and have children later in life, there are 3 main consequences. The first one is rising rates of infertility. The second one is more abnormal pregnancies or embryo aneuploidy. And the third one is increased prevalence of miscarriage. So just to put this in context, when we look at the biological inequity, 1 sperm sample to be normal has more than 40 million sperm. And spermatogenesis continues basically in perpetuity for men. So even when the sperm looks like this, and this is from our lab, you can see that most of the sperm in this sample are dead. The few that are alive are lost and like swimming around in circles there. Even samples that look like this, after we wash them and activate the sperm, can often look like this, where there's many motile sperm to work with, especially with assisted reproductive technology. Now, contrast that to the ovaries that have maximum usually 1 million eggs at birth, and that number declines throughout the lifespan. So I'll draw your attention here to ovaries in their 20s have still, in the hundreds of thousands of eggs, but it's really in the 30s and the late 30s particularly where the numbers drop drastically. So ovarian reserve decreases, and that is a non-renewable resource, and that can contribute to infertility. Many of you are familiar with ovarian reserve testing. Just to review a little bit of the data around that, of course, Life Labs here in BC covers day 3 FSH, so most of us do it. It's a pretty crude test of ovarian reserve. Generally, I would say that when it's over 7, we start to think that the pituitary is sort of speaking louder, maybe yelling at the ovaries. So it's really the pituitary is kind of having to yell at the ovaries, which is a sign that the ovarian reserve may be decreasing. This graph here is taken from IVF data, but what it's showing you is like the red line is the youngest age group, less than 35 years old. The blue line at the bottom is the oldest age group, over 43. But in all age groups, when the FSH is above 7, you can see that the fertility rate starts to drop. So we think that when it's above 7, it starts to be sort of a late measure, but a sign of decreasing ovarian reserve. Antral follicle count is done in real time by transvaginal ultrasound. We do it on all of our patients, but it's really a fertility doctor thing. If you get a report back from an outside ultrasound that says polycystic ovaries, it just means in general that they counted more than 20 follicles in that ovary. AMH, I would say, is the quote unquote best ovarian reserve test. AMH, of course, is important for male fetuses because it causes regression of the Mullerian structures, which is really the fallopian tubes and the uterus. And we didn't really think AMH had a role in females until more recently when it was discovered that it has a direct correlation with how many eggs we can get at IVF. So it really is an accurate ovarian reserve measure. And that's because it's produced by the granulosa cells in the follicles. So if you see here on this diagram, the purple cells, those are the granulosa cells. So essentially, if you have more follicles, you have more granulosa cells. If you have more granulosa cells, you have more AMH. So higher AMH, more eggs, essentially. And the reason that it's convenient is because you can do it any day of the month. It's not produced by the granulosa cells in the dominant follicles. Essentially, it's stable throughout the month. You don't have to wait for day 3. At Life Labs, they charge you just under $80 for this, but in Alberta, my understanding is that it's covered by health services. I think it's the interpretation of AMH that trips people up because Life Labs, when they publish their nomogram, is super wide, goes from 2 to 50. That's not really that helpful when you're counseling your patients. These are 2 nomograms. There are many online. If you like this, you can screenshot it and keep it for future reference. On the left here, you can see that the age is at the bottom, and you can see that the AMH in picomolars, which are the Canadian units, is here on the y-axis. So, there's percentiles, and you could stratify your patient's result in terms of percentiles by age. I really like this graph on the right-hand side here. The only caveat is that it's in nanograms, which are the units for America. So it's kind of like converting miles to kilometers. You have to multiply the Canadian value by 0.14. So I just put that in red with an example at the bottom there. But I find this really helpful because you can take your patient's value and then actually show them, are they at the 5th percentile, 25th percentile, they average or below average for their age. So that's AMH for ovarian reserve testing. Now, it's important that we tell patients, it's good to live healthy. Some people come to me and they do yoga and they eat vegan and they take all these supplements and they say, well, I must be more fertile. It's not necessarily true that you keep your ovarian reserve as a result of healthy living. The opposite is true. You can certainly make it worse by, smoking, chemotherapy, radiation, things like that kill those ovarian follicles. But you can't make your ovarian reserve better by healthy living. So it really just is, the march of time that causes that decline in ovarian reserve, unfortunately. One of the other things that happens as the eggs get older is they're more prone to genetic mistakes or aneuploidy. And this is the result of numerous things that are happening within those eggs, but generally they tend to be errors in non-disjunction. So what that looks like, if you look at this example on the right, is that the oocyte starts with 2 complete sets of genetic material. And then in meiosis 1, the first polar body is extruded, and you should have half of the amount of genetic material. After meiosis 2 is complete and the second polar body leaves, you should have separation of those sister chromatids so that one copy of the chromosome comes from the egg and the other copy comes from the sperm. If you have non-disjunction, like this blue example here, then you could end up with those sister chromatids. Yep. Oh, you could end up with those sister chromatids not separating, or you could end up with the sperm fertilizing an egg that has no sister chromatids. So that would be monosomy, because it would have one copy of the chromosome, or trisomy here, where it would end up with 3 copies of the chromosome. So eggs are never perfect. Whenever even young women have miscarriages, I always counsel them that this is normal. Unfortunately, it's heartbreaking, it's emotional, but it's also normal. So you can see that embryo euploid or normal embryo rates are sort of prime, like in the late 20s and early 30s. But even then, 10 to 20% of embryos are going to be abnormal. But where it really climbs steeply is in the late 30s and into the 40s, where you're going to have well over half, or even 60, 70+% of embryos are going to be aneuploid. So I think we've answered the question about why we need to talk about egg freezing in terms of having pregnancies later in life and the physiological effects on the eggs. Let's talk now about when. Really, when is the best time to freeze the eggs? Because we certainly do not want to incite panic in our young patients where they think, oh, I have to freeze my eggs at 25 if I don't have a partner. That's not the case. So do we have data to answer that question? From a cost effectiveness standpoint, this study was what's called a decision tree model. So what they were trying to do is estimate the optimal age to pursue egg freezing between 25 and 40 years old. And they had this decision tree where they considered marriage or no marriage. So essentially using the eggs regardless of whether you got married or waiting for marriage. And what they found is in Model B, assuming that women were going to use the eggs regardless of marriage, the difference in live birth rate was above the threshold of benefit, which was a 10% benefit, for everybody over the age of 30. So essentially it's helpful for everybody over the age of 30 and cost effective for over the age of 30. It was most cost effective at age 37 with a 29.7% benefit. So these authors concluded that 37 was the most cost effective time to freeze your eggs. I want to show you this graph that they demonstrated, because even though 37 was the most cost-effective time, if you look at the black squares and the black triangles here, you'll see that actually across all ages, the triangles are always lower. So that's the model in which they did not do egg freezing. So whether you're 26 or 34, without egg freezing, according to this model, fewer babies are going to be born, but it's most cost effective because you might meet somebody and never need the eggs at age 37. This is another study looking at expanding the reproductive lifespan and the strategy of either doing egg freezing at age 35 and then using the eggs at 40, or never doing egg freezing, just try to get pregnant at age 40, or the reference strategy, which was considered try to get pregnant at age 40. If it doesn't work, then do IVF. So what's going to result in the most babies and what's the most cost effective? And what they found was that the most babies are going to be born if you freeze eggs at 35. So the live birth rate predicted with this study was 84.5%, but the cost was 10,000 euros. The live birth rate with just never doing egg freezing was 52%, but the cost was 300 euros. I don't know what the cost built into natural conception were for this particular study. And then waiting till 40 and doing IVF, it was 64%. So what they concluded was the most babies are going to be born with egg freezing at age 35 and using those eggs if necessary at age 40, but that does come with a cost, and it's not cheap. estimated at more than 10,000 euros. And then finally, in terms of what age to freeze the eggs, do we need to rush out and encourage everybody to freeze their eggs at age 25? I would argue the answer is no. There's no need to panic. When we look at the number of eggs that we need, that's here at the bottom of the graph. And the cumulative live birth rate, which is here on the y-axis, we can see that the 18 to 29-year-old age group is the blue line. And the 30 to 34-year-old age group is the pink line. You can see that they're really similar. So I think this shows us that into the early 30s and up until about age 34, the results are really good with egg freezing. There's no need for women in their 20s or mid-20s to be panicking into feeling pressure to freeze their eggs. The 35 to 39 age group is the orange line, and that number is lower. So certainly the success rates here predicted are still good, but they're not nearly as good as the early 30s. And this data says the same thing. This is another egg freezing calculation model that shows basically that donor eggs, which are considered to be the best prognosis eggs, give you about a 75% live birth rate predicted with 10 eggs. And for the autologous eggs, 12 eggs in patients under 35. So still really similar. There's a little bit more granularity in this graph, so you can see like age 36 and certainly 37, the curve starts to shift to the right. So you just need more eggs, which could mean multiple egg freezing cycles in order to get that same predicted live birth outcome. The other thing I always say to patients is there is no 100%. It doesn't matter how many eggs we have in the freezer, this is not a guarantee of live birth. When we talk about egg freezing and cost effectiveness, we don't want to be freezing eggs for a whole bunch of people who are never going to need them or come back to use them, right? So this is about choosing the right treatment for the right patient. The data that we have, the oldest data is this study at the bottom, which comes out of NYU. And these were eggs that were frozen even before the experimental label was removed. So this is back to 2005 in New York. And if we look at a 15-year time horizon, about 38% of women have come back to use those eggs. So that's the highest number reported in the literature. Other numbers range from 9 and 16% of women have come back to use those eggs, or people have come back to use those eggs. In PCRM, just a couple of weeks ago, we published our data at the Canadian Fertility Andrology Society. So looking at, and this is the largest series published to date of any Canadian clinic, 665 egg freezing cycles, 80 people had come back so far to use those. But these were eggs that were frozen between 2016 and 2024. So they don't go back as far, but 12% so far have come back to use their eggs. So I think in terms of when, it's biologically optimal in the late 20s and early 30s, but financially, according to the data, cost effective in the early 30s, probably up until age 37. Okay, so we've answered why, we've answered when. Let's talk a little bit about how. Many of you probably know that the egg freezing process is very similar to the IVF process. So it starts with 8 to 12 days of subcutaneous injections of gonadotropin. So that would be follicle stimulating hormone, as well as an antagonist to block ovulation. So that's an example of what the drugs look like. Patients would come to the clinic generally between 7 and 9 a.m. and we measure the follicles as they develop on the ovary. When they get big enough, we give them a trigger shot. And then 2 days later, under conscious sedation with midazolam and fentanyl, we do a transvaginal procedure where a needle goes through the top of the vagina into the ovary and we suck out the eggs. It's really important to freeze the eggs with an experienced provider because the eggs are very, very delicate. They're round, they don't permeate easily with cryoprotectant, and they're at metaphase when we freeze them, meaning that their genetic material is completely splayed out and vulnerable to ice crystal formation. It's also just one cell. So this is an all or nothing. It either survives or it doesn't survive. So eggs are very delicate. This is what they look like when we freeze them. And we use a technique called vitrification, which is otherwise called flash freezing. Essentially, they're immersed in liquid nitrogen and stored at negative 196 Celsius. So the eggs, or the zona, is this halo you can see around the outside. We know these eggs are mature because we can see the first polar body's been extruded. And these eggs are really nice. They have nice, clear, even looking cytoplasm or ooplasm. This is an example of the dewars or the tanks that they're stored in liquid nitrogen. They're monitored by power, but of course they're not dependent on power to stay frozen. This is Gina from our lab doing an egg thaw. So she's actually taking the egg that's frozen at the end of that straw. And what it'll do is sort of float and release from the straw. And then under magnification, it's transferred into various solutions through the egg warming process to sort of rehydrate it so that it's ready for fertilization. When it comes to fertilization, we do ICSI. So if you look at this picture, before I hit play, you can see there's a little sperm in the ICSI needle here. And what the embryologist will do is gently inject that sperm into the egg. And then the embryo would be left in the incubator for 5 days so that it will grow into a blastocyst. So this is a video of one of our embryologists in the lab, just gently placing the sperm. You can kind of see the sperm kind of rush through the needle there. So that's ICSI. So elective embryo freezing and egg freezing has been really increasing in popularity. This is the latest data from the Canadian Fertility Andrology Society. The orange line is egg freezing. So you can see that, it was kind of ticking up around 2014, 2015, 2016, but huge increase, particularly after COVID. So this is something that we're seeing more, and probably, I would imagine your patients are asking you more about in the community as well. So let's talk to you about our outcomes. This is data presented a couple of weeks ago at CFAS, so hot off the press. Again, this is the largest cohort of Canadian data presented. So this is 8 years of data. 8 patients have come back to use their autologous eggs that are frozen. We do lots and lots and lots of frozen donor egg cycles, but these are patients who froze their own eggs and are now coming back to use them. So there's 854 eggs in this series. A lot of them were elective egg freezing, so 56%. But some of them were egg freezing because there was no sperm. And that's, again, because we are a micro-TUSSY center of excellence. So a lot of people are going through, and then their husband is undergoing a sperm retrieval process if there's severe male factor, for example. When people come back to use their eggs, it's interesting, actually, that a good proportion, 36%, are using donor sperm. So this would be like single mothers by choice who are using their eggs and starting a family on their own, same-sex female couples, as well as severe male factor infertility. And then let's just cut right to the results. So looking at the cumulative clinical pregnancy rate. So how well do these eggs actually do? It's not surprising that in the younger age groups, the outcomes are better. So the cumulative clinical pregnancy rate under 34 is 71%. Between 35 and 37, it's 62%. And between 38 and 40, it's 53%. There's a small number of patients who froze eggs over 40, but you can see that we haven't had pregnancies from those eggs frozen over age 40. So how do these compare to worldwide published data? I wanted to give you an overview of the latest and the largest studies published to date. You can see that in terms of our egg survival rate of 83%, this is comparable with published data, where the survival rate ranges from 76 to 85%. And then the cumulative clinical pregnancy rate is comparable with our fresh egg cycle. So this is really important to demonstrate that the frozen eggs appear to do as well as fresh eggs. So 71% versus 64% for women under 34, 35 to 37-year-olds had very similar 62% and 62%, and 38 to 40-year-olds, 53% and 52.9%. In terms of egg freezing safety, this is another study that's hot off the press, published in 2024, looking at the American Registry of ART data. And the reason I wanted to show you this study is because this is looking at fresh versus frozen donor eggs that were transferred into gestational carriers. So the real importance of this study is that we're using donor eggs. So it takes away the ovarian stimulation because they are being transferred into gestational carriers, which also takes away the uterine comorbidities that could be present. So it's really the most sophisticated study to date that I have seen to isolate the distinction between fresh and frozen eggs without any of the other comorbid or the other complicating factors, confounding factors. And what they found was that there was no difference in live birth, no difference in miscarriage, and no difference in low or high birth weight infants. Now, unfortunately, this study was just published. They haven't followed these pregnancies into, infants or children. There is a study that has looked at the health of 2-year-old children born after frozen eggs that were donor eggs and compared them with fresh donor eggs. And they found no difference in the health or growth of the 2-year-old children, looking at 72 children that were born after frozen donor eggs. So is this a lot of data? No. Do we want more data? Yes. However, the data we do have so far with regard to fresh versus frozen eggs looks reassuring in terms of the health of the eggs, the outcomes, as well as the health of the resulting infants. So I hope we've answered the why, the when, and the how. Now, just a couple of practical tips, and then we'll leave time for questions. Of course, cost is always a question. So the cycle cost presently is $8,850, and medications, if not covered by a drug plan, can range depending on the ovarian reserve. But in general, egg freezing cycles are $14,000 to $18,000. And this doesn't include the cost to society and time off work. So of course, we would consider that. In conclusion, birth rates are declining and mothers' ages are increasing. So patients may be asking about egg freezing. It's optimal biologically between 25 and 34, but data would suggest that up to 37 is the most cost-effective time. And it does appear to be safe and effective, although a small proportion of women so far have come back to use their eggs. The safety data is early, but so far it's reassuring. Okay. And that is it. I will leave some time for questions.
Excellent. That's a great review, Caitlin. Thank you for covering so much in such a concise format as well. Couple of questions from the chat. One is, can you measure AMH or FSH while on the birth control pill?
So the answer is AMH, yes, absolutely. It's valid on the birth control pill. Some studies would suggest that it's a little bit lower in long-term users of OCP. However, those estimates are about like 10% difference. So I still think it's really helpful because if it's super high and it's 10% difference, then it's still high. If it's really low, if it's 6 picomolars and then the real answer is 6.6, that's still pretty low. So I would say it's not worth having to take the person off the birth control pill just to do the AMH. FSH, no, you can't measure. It's going to be suppressed because of the exogenous estrogen in the birth control pill that shuts off the FSH secretion. So you really need like a week washout from the pill to do the FSH. But again, AMH is so accurate. Is it worth taking the patient off the pill for a week just to do an FSH? I mean, my answer would be no. But certainly you could wash out for a week and then do the FSH.
Great, excellent. So the second question, the effect of cannabis on ovarian reserve, any comments?
Oh, that's a really good question. I don't know that we have good data about cannabis on ovarian reserve. The studies that we have on cannabis, I wrote a review article about this for the BCMJ a while back, and they're generally like population studies. And in the questions, they ask people, do you use cannabis? And then they look at who had babies and they try to tease it out that way. And it didn't seem to have an effect. That's not really that good in terms of the data. So the answer is I don't have a good answer for you about whether cannabis lowers ovarian reserve. Certainly smoking does. Certainly smoking does. So you would think that some of those combustible agents might have a similar effect, but I don't have specific cannabis data to answer that question.
Another great question that we actually get a lot of these questions with our patients. Is there a difference in live birth rate successes using frozen eggs based on the age at the time of pregnancy? So, for example, in this question, if you froze your eggs when you're 30, but you got pregnant when you're 35 versus 40 versus 42.
Yeah. So the short answer is in our business, we like to say the uterus doesn't age. So let's assume that the patient stays healthy. Her lungs are healthy, her heart is healthy, obesity, all of those things, fibroids don't develop, et cetera. Let's say we're just talking about the uterus. Essentially, when you look at if the egg stays the same age and the woman gets older, the pregnancy rates on the SART data are flat. So the short answer is as long as pregnancy is healthy in that patient, the specific age of the uterus, barring those other sort of confounders I mentioned, should be fine. And you can use frozen eggs until age 50 at our clinic.
Excellent. Great. Do you have time for one more question?
I want to let Dr. Ilnitsky start on time. So maybe what
Sounds
I'll do
good.
is I'll type the rest of the answers in the chat.
Perfect. Perfect. Thanks again, Caitlin. Excellent.